you want me to share my screen or do you want me to wait?
No. Welcome to the Cannabis Research webinar for July. Thank you for joining us. We will get started shortly, but first, we would like to allow a brief moment for attendees to join the webinar. Hello, my name is Jodi Gilman. I'm the Grants Manager and Program Officer for the Institute of Cannabis Research, hosted at Colorado State University, Pueblo. Welcome to the Cannabis Research webinar series, which is presented by the Institute of Cannabis Research and the Lambert Center for the Study of Medicinal Cannabis and Hemp at Thomas Jefferson University. This webinar series, in collaboration with the Lambert Center, is one of the many ways that the ICR works to promote the dissemination of cannabis research. For example, please see our website, which can be found by Googling the words Institute of Cannabis Research, and from there you can navigate to our outreach tab and find the current e-newsletter for the ICR. Also, you can navigate to the research tab on our website to view the summaries of each of the research projects that the ICR is currently funding. You can also find information about our future webinars, which we present each month. Also, please note the link to the Journal of Cannabis Research, which the ICR sponsors. The journal is published by the prestigious Springer Nature and is always looking for both highly quality scientific article submissions and reviewers. We also will be hosting the 7th annual Cannabis Research Conference this August 3rd through 5th in beautiful Denver, Colorado. And stay tuned to our website for updates. The conference will feature over 143 presentations and a number of exciting keynote speakers. The conference will be a place of different collaborations and innovations for the field and industry of cannabis. Before we get started with the presentation, I'd like to mention some logistics for the items for the webinar. Today's presentation will be followed by a short question and answer period. To ask questions, please do use the question and answer feature in the Zoom toolbar. You can enter questions at any time during the presentation. We will address as many questions as time allows us until the end of the hour. Please reserve the chat function in Zoom for technical issues and questions. Both the question and answer and chat functions can be found in the toolbar on your Zoom screen once again. It's now my pleasure to introduce my colleague, Ruth Chabourneau, the Associate Director of the Lambert Center, who will be introducing today's presenter and moderating the webinar.
Thank you. We're pleased to have Dr. Jodi Gilman, an associate professor in psychiatry at Harvard Medical School and the Director of Neuroscience at the Massachusetts General Hospital Center for Addiction Medicine. Dr. Gilman's research uses multi-modal imaging, behavioral, and cognitive testing to understand the biological, psychological, and clinical aspects of addiction. Her goal is to conduct research that can inform decision-making among the public, patients, and clinicians regarding evidence-based decisions to use or not use cannabis for recreational or medical purposes. I'd urge you to look at her full bio on the ICR website, but I'm pleased to welcome her and her presentation on identification of THC impairment using functional brain imaging. And with that, I'll turn it over to you.
Thank you so much, and thank you for inviting me to speak today. This is really an honor. So let me share my screen. Put it in slideshow mode. Are we good? Thumbs up?
Good.
Okay. So I'd like to talk to you about some work that we've done identifying THC impairment using brain imaging. And the reason behind this work is because, as you can imagine, cannabis and driving don't mix, right? You don't want people high behind the wheel. However, the true crash risk of THC is actually quite challenging to get your finger on. And we know that cannabis impairs psychomotor skills like divided attention and lane tracking and cognitive functions, and we can show that in the laboratory. But NHTSA's crash risk study showed that the odds ratio for THC was 1.25, so a 25% increase in the rates of car crashes when people had cannabis on board. And then when you adjust the odds ratio for demographics and gender and age and race, the adjusted odd ratios basically disappear. They're around 1. So how is that possible? Anyone who's used cannabis will know that, you know, you get all sorts of altered perception and reaction time. So how's that possible? Well, what I think is that the true crash risk is an open question because studies underestimate risk. Because a lot of people who test positive for cannabis are not impaired. So if you can imagine, there's a crash, you get people, you know, you test, people are usually not even tested, but let's say you do drug tests on the driver and they're positive for THC. Well, that doesn't mean they were high at the time of the crash. That means that they are a cannabis user and they could have used in the past, you know, week or 2 or even month. So it really waters down those odds ratios. And so this, you know, this means that we really need a test for impairment, not just a urine test. Because this is such a sort of a difficult problem, the THC impaired driving laws are literally and figuratively all over the map, as you can see. So there are 12 states that have zero tolerance laws. So if there's any THC in your urine, you're considered impaired. And I think anyone who is in the cannabis field will know that that's ridiculous, right? Basically, you're making a statement that anyone who uses cannabis anytime can't drive a car. 5 states have these per se laws, so they have cutoffs between 2 and 5 nanograms per milliliter of THC itself in blood. THC is different than the metabolite carboxy THC, which I'll talk about a little bit. Your state of Colorado has this permissible inference law, and most states don't even have any specific cannabis laws because they don't know what to do with it, quite frankly. So in order to understand why this is such a problem, let's talk about THC and carboxy THC. So THC is the main psychoactive compound in cannabis. It's absorbed through the lungs. It reaches high concentrations in the blood, and its peak plasma concentration is attained within 3 to 10 minutes. That's THC itself. And then the THC plasma concentrations decrease rapidly after the end of smoking because THC is distributed into tissues. And THC is metabolized into a few intermediate compounds, and then finally carboxy THC. So here you have THC and then carboxy THC. And let's talk about THC first. So here's some data showing the THC concentration in breath and in blood after you smoke a joint. So as you can see, it peaks rapidly and then it falls rapidly in breath and also in blood. So, you know, by 30 minutes, you know, it's just a fraction of what it was when you first smoke a joint. But how long are you high, right? So you have these, you have the serum THC concentration, so that's the blood, and same for other bodily fluids. But then you have the subjective high. So they ask people, you know, how do you feel? And as you can see, there's a really big gap between what your blood says and what your brain says. So there's problems with inferring impairment from fluid or blood levels. So you have THC itself, where the window is too short. For inhaled THC, it's minutes to maybe 1 or 2 hours. You have carboxy THC, where the window is too long, because carboxy THC is what you would think of as a traditional drug test for a job interview or something, and that's detectable for days or even weeks. And then impairment is right in between, 1 to 5 hours, sometimes more. And this is a nice graph of that, where you have, you have breath, you have oral fluid, you have blood, you have urine, and then you have hair, which, that can be positive for a year, especially if you have long hair like me. And to add to the problem, people have poor insight into their own impairment. So this is a really nice paper that was just published in JAMA Psychiatry, where this is a composite drive score after THC administration. So worse is higher. So as you can see, 30 minutes into the task, they're doing pretty bad. An hour and 30 minutes, they're still doing pretty badly. And then they eventually reach baseline. And this is their perceived impairment. So 30 minutes, they know they're impaired. So maybe they won't get in the car. But then look at an hour and a half later. So hour and a half, they don't think they're very impaired, but their driving score is still quite impaired. So there's this gap. And that's when people may get into the car and drive because they think they're fine. Okay, now this problem gets worse. The problem gets worse because dozens and dozens of studies have shown no association between THC biomarkers and impairment. This is now established science. This has been published over and over again. So blood and oral fluid, THC, and metabolite concentrations are just not related to impairment. They're just not. It doesn't behave like alcohol. Alcohol is easy. There's some tolerance issues with alcohol, but generally you're at 0.08, you're impaired. You shouldn't be driving a car. THC, it just doesn't work that way because the pharmacokinetics and pharmacodynamics are just a lot more complex, and tolerance is a much larger influence than it is for alcohol. And this is the best meta-analysis that I've seen is they reviewed 28 publications and 822 driving related outcomes and basically concluded what I said, that per se limits need to be reconsidered, that like an amount in blood doesn't correlate with impairment. And there's a lot of risk of unimpaired individuals being mistakenly identified as cannabis impaired, and vice versa. So there's also, if you do that saliva test or blood test for THC, you have people who are impaired, and their test makes it look like they're not impaired. So a breathalyzer just isn't going to work. So what might work for this problem? So what do we have? So we have these standardized field sobriety tests that have been adapted to cannabis. So you have, drug recognition experts or these specially trained cops who can do these cannabis assessments, but scoring can be arbitrary. It can produce false positives. We've shown that in our work, and other people have shown that too. Indicators are based on alcohol impairment. Cannabis is not like alcohol. This test is not validated, and it's just not accurate for identifying cannabis impairment. And we've shown that now twice in 2 different papers, and we're about to publish a third. What else could we do? So some people are trying to develop this app. It's called the Druid. It's super cool. I've used it. It's fun. But this also isn't perfect because you need a baseline measurement. So you need to do a cognitive test, before you're high, and then it could compare your performance when you're high and say, okay, if it's so much worse, then you're probably high. And it's an app on your phone, but you need the baseline measurement. And I don't know how many people are going to do that voluntarily. And there's no way for law enforcement to compare a roadside score with an unintoxicated performance. So that's a problem. Then you have these drug tests that are being developed to analyze THC. But again, testing positive on this thing doesn't mean you're impaired. So there's this false positive risk. So this is where I come in. So we were thinking, is there a test that can go for the source of impairment, which is the brain, right? When you break a bone, you take an X-ray. In the case of impairment, your affected organ is your brain. And other methods look for correlates of impairment from bodily fluids like blood or saliva or urine, which replicates the alcohol model, but it doesn't work for THC. So my background is in functional MRI. These are these giant machines that cost millions of dollars and need to be in a room with no magnetic material. That's not going to be roadside ready. But there's another neuroimaging technique called functional near-infrared spectroscopy, or fNIRS, which is portable, lightweight, and cheap. It uses light to measure brain activity along the same principles of fMRI. So fMRI uses magnets and fNIRS uses lights. It's non-invasive, it's safe, it's inexpensive. The idea behind this for this purpose is to measure impairment and not just exposure, and it's portable and wireless and can be used in natural environments. So this is what it looks like. There's this, funny one with wires coming out of it, and these were the original ones, but now there's some more sleek looking headbands. And this is often done on babies because it's scary for a baby to go in an fMRI machine because it's loud. You have to give them earplugs. They can't move. But, a lot of babies do these fNIRS studies because, they just go on your head. And so just going back to the physics of this, and I'm not a physicist, so I hope nobody asks me for a lot of detail, but I'll do the best I can. You measure brain tissue concentrations of oxygenated and deoxygenated hemoglobin, which changes when a brain region is quote unquote activated. And how do you measure these changes in oxygenated and deoxygenated hemoglobin? You shine NIRS light into the head. So this is called the hemodynamic response function. So you have neural activation. So I ask you to do a task, math, or watch a checkerboard. And there's neuronal activation, which leads to metabolic demand, which leads to increased blood flow, which leads to increased oxygenated hemoglobin and washout of deoxygenated hemoglobin. So you're looking at a ratio. And there's differential light absorption between the oxy and the deoxy hemoglobin, which allows you to measure this brain activity. So here's an example of an increase in HBO, oxygenated hemoglobin, following a task. So you have a little memory task. You have to respond to the X. So, at time 0, you start showing the task. They respond here. And then you see this increase in oxy hemoglobin, this decrease in deoxy. So we can say in this period, the brain has been activated. Okay. And just one more slide on this. How can light be used to detect this? You have sources and you have detectors. Your source is where you shine the NIRS light into, and the detector is where you detect the NIRS light as it's gone through the tissue, and it makes this little banana shape. And basically, more activity means more absorption of light at different wavelengths. So if a brain region is active, you'll have a higher ratio, and if a brain is not active, you'll have a lower ratio. And the sources and detectors are 3 millimeters apart, because very smart people have determined that that's sort of this banana-shaped feature where you can shine light in one place and detect it in another. All right, there's your physics lesson. Now we'll talk about cannabis. Oh wait, not yet. One more thing about fNIRS. The cool thing is that it allows neuroimaging in these ecologically valid settings. So you have people walking, you have people driving, you have people playing the violin. It's pretty cool. And compared to other neuroimaging methodologies like fMRI or EEG or PET, it's very good for any kind of portable task because it's robust to motion. Anyone can do it. It's silent, and the cost is low. And this is something that I like to tell people. This was the first breathalyzer. It took an entire desktop, and now we have these little things that are the size of your phones. And fNIRS, same thing. They used to be big, bulky machines, but now they're tiny little chips and little headbands. So it's not that non-feasible that we could use fNIRS in the same way that we use breathalyzers someday. All right, now I'll talk about cannabis. So our studies use fNIRS with cognitive tasks to predict impairment. So in this study, we had 169 participants participate in the study, and they were weekly or more cannabis users. They were all fairly experienced. They had visits 2 weeks apart. Once they got THC, once they got placebo. And we did fNIRS recordings that were 6 minutes long during a working memory task, which is an NBAC task. We did it before THC or placebo, and then we did it at 100 minutes. We gave oral THC, so peak effects were expected around 100 minutes. And then we did it again at 200 minutes after the administration, where we expected some of the intoxication to resolve. And we had evaluation for impairment by a certified DRE, and that's the cop that's specially trained in this. I'll tell you how they did later. What dose did we give them? So we did individualized dosing to achieve impairment between 5 and 80 milligrams of synthetic THC. Why? Because we needed to get everyone impaired, and people varied so much in what it took to get impaired. So we would do an interview. This was based on self-reported use patterns, self-reported intoxication. We'd ask them, what do you usually use? How high do you get? Do you have any adverse events? And THC potency has increased so much in Massachusetts that it was necessary to give these really high doses. We estimate that around 60% got impaired with these doses. Now, how did we determine who was impaired, right? That's sort of this critical question that took us about a year to answer. So we figured we would use the DRE results, but then we found that 20% of people who received placebo were deemed impaired by the DREs. And there's also inconsistency between them. So one guy had a 92% accuracy and one guy had a 50% accuracy. So we were like, oh, we shouldn't use this, as the ground truth of impairment. So what did we end up doing? We employed 2 methods of assessing impairment. First, we had a clinical consensus rating. So we had blinded raters interact with them, look at their results of cognitive tasks, look at their self-report, and got a clinical impression of whether or not we thought they were impaired or not from basically their behavior during the study session. And then we had a computer-based algorithm where we looked at heart rate and self-reported high. And both methods need to agree for them to be considered impaired in our study. The clinical consensus ratings, like I said, it took into account self-reported high and heart rate, and the blinded study staff and the blinded nurse. And sometimes we had a driving simulator, but we got that late in the study, and the dose of study medication. And then the algorithm just looked at two indices. It looked at their heart rate from baseline, and heart rate is a strong correlate of intoxication. And it looked at their self-report, and we had a cutoff score that was algorithmically based. And I'm not going to go into this because it's complicated, but basically you had self-reported high from 0 to 100, and we had change in heart rate up to 90 beats per minute. And we looked at the people who were outside of normal ranges. So anyone who's above around a 60 in self-report and had above a 27 of heart rate were considered impaired. And there's a lot of variation. So here's an example of a person who got 30 milligrams of THC, and this is a time course. And this is their self-reported high over the time, and this is their huge bump in heart rate. So we said, yeah, that person looks impaired. And then this is the same person on placebo, so 30 milligrams of placebo. Different person got 30 milligrams of THC and showed nothing. So we just didn't succeed in getting them impaired. Okay, and then we looked at the people who were impaired for our machine learning, which I'll talk about in a minute. So the two groups separated really nicely. This was self-reported high of our impaired group. This was self-reported high of our not impaired group, and this was our placebo. Same with heart rate. This was the impaired group, nice heart rate bump. This is our non-impaired group, and this is placebo. And these gray bars are when the fNIRS took place. The other important thing to point out is the doses weren't different between the impaired and the non-impaired. So dose is not a good proxy for impairment for the reasons I talked about before. Okay, so did they differ on our fNIRS measurements? So here's the cap. This is a schematic of the channels, yellow sources and red detectors. And we looked at the sources and detectors made a channel, and we looked at the HBO at each channel over time. And what we found was that although there was no difference in THC dose, this was the time course of the HBO at baseline, so before study drug was administered. And this is the HBO after study drug was administered. Remember, that was a separate day. And we found a significant difference between before versus after study drug only in those who were impaired. And this was throughout different regions of the brain. The people who weren't impaired, we saw nothing. They got THC, but we did not see a difference in the HBO response, which we thought was really interesting. Okay, so the next thing we did, so we had this group level data, and we published on this, and we thought it was really cool, but that's not very useful in the real world. So group level data is cool for a scientific paper, but if you want to determine who's impaired, you really need to look at individual subjects. And psychiatry has really struggled with diagnosing psychiatric disorders based on individual functional data. It's hard to do, and often you need some kind of machine learning algorithm to really get at the features that would predict the psychiatric diagnosis, or in our case, impairment. So what we found, and this was, very cool to us and somewhat surprising, is that we could predict with machine learning by breaking these time courses into features. So first I want to show you the DRE. So we wanted to see, how accurate was the DRE? So that was the comp in assessing who is impaired. And they were 72% accurate in agreeing with our clinical consensus. Their positive predictive value of which means of those who were called impaired, how many were really impaired, was about 37%, and their false positive rate was 35%. So really high. Now, how do we do with fNIRS? So when we looked at the fNIRS data from each person, the accuracy was 76%. Positive predictive value was 70%, and our false positive rate was 12%, which is still too high to be used as an actual legal standard. We want to get that way down. We want it to be below 5% or even less. But we still thought we were onto something, and it was still significantly lower than the DREs. Okay. What if people aren't going to do a working memory task? What if they cannot or will not do a working memory task? So the next thing we looked at was resting state functional connectivity. So far we talked about measuring changes in HBO during a task when they're doing their memory task. But we can also look at functional connectivity, which is how brain regions are interacting with each other. And this can be done at rest without the need for a task. And what you're looking for is temporally correlated but spatially distant brain activity. So if brain activity goes through, as it increases and decreases together, but you're looking at one region here and one region here, you would say there's significant resting state functional connectivity between them. So we had our channels in the brain. And again, this was all the prefrontal cortex. And then we had our ROIs. We had the right DLPFC, the right VLPFC, the medial prefrontal cortex, left dorsolateral prefrontal cortex. And we looked at how these regions were talking to each other. And what we found was that we saw decreased functional connectivity only in those who were impaired from THC. So the group that got impaired for THC, this is what it looked like before they got any THC, and this is what they looked like after. So they had decreased connectivity from pre to post THC. Those who were not impaired from THC, we didn't see any differences in their functional connectivity. And another way of looking at this, instead of pre-post, this is before and after they got THC. Another way of looking at this is placebo versus THC. So the people who did not get impaired from THC, this was their resting state connectivity on placebo and on THC. Not that different. But the people who got impaired, this was their resting state connectivity on placebo, and this is what they looked like on THC. They had dramatically decreased functional connectivity. And then we were able to do a similar thing with machine learning, where not using our NBAC data, but using our resting state data, we got similar accuracy, similar predictive value, and a slightly higher false positive rate, but still what I thought was an impressive false positive rate of identifying impairment only based on resting state connectivity. Okay, finally, and I'm going to wrap up so we have plenty of time for questions. We wanted to look at alcohol to see if alcohol interfered with our ability to detect impairment from THC. And as you can imagine, alcohol has effects on the brain. THC has effects on the brain. They're often used together. And you wouldn't want people to be high on THC and then have a few drinks and then look, quote unquote, not impaired by this test, because that would defeat the purpose. So we gave a subset of participants an alcoholic beverage or placebo in addition to THC or placebo. So it was a 2x2 design. They could either get real THC, placebo alcohol, placebo THC, or real alcohol, both together, or two placebos. And what we found among people who are impaired from both THC and alcohol, so that's the blue, is that we kept seeing these decreased connectivity from pre-dose to post-dose. So this is still sort of preliminary. We haven't published on this yet, but we don't think that alcohol is affecting our ability to detect impairment from THC. Okay. We also replicated the fact that people are not always self-aware of their impairment. And I showed you this earlier, but this is percentage of people who said yes to would you drive right now. We asked them every 20 minutes during the study, would you drive right now? So in the beginning, most people said yes. Some people said no, I don't know why. I had one person say, I wouldn't drive right now because I don't know how to drive. So we should probably remove those people in the future. But as you can see, as the study went on and time elapsed, fewer people said yes, they would drive. But there was more people said they wouldn't drive who we called impaired than who we called not impaired, which is what you would expect. The people who didn't feel a huge effect from the THC were more likely to drive. But even the impaired people, more than 25% of them said they would drive, which to us was a little bit striking because we gave people these massive doses of THC. So just wrapping up, what we found in this series of studies was that prefrontal cortical activation collected with portable fNIRS appeared to be somewhat of a biomarker for THC impairment that can be collected in the field. This was collected in the lab, but we think that the promise of fNIRS is that it is portable, it is wireless, it is battery operated, and it could be collected in the field someday. The biomarker was different only in those who were impaired. And this is the first biomarker of impairment from THC rather than THC exposure. So many studies look at the brain before and after THC exposure, but they don't take into account THC impairment. This biomarker can be detected when people are doing a task or when they're at rest. So our next steps are to determine if this neural signature is specific to cannabis or to all impairment. right? So we'll have to get people impaired from benzodiazepines, opioids, certain psychiatric medications that can be impairing. And we can see, you know, does this test need to be paired with a urine or a drug test, or is it standalone? I would hypothesize it would need to be paired with a urine test to show presence of cannabis and impairment together. We want to test how combinations of drugs that are commonly used together, such as THC and alcohol or THC and opioids, affect these fNIRS measures. We need to test how neurological medications or neurological or psychiatric conditions affect these fNIRS measures, because as you can imagine, there's sort of an endless range of possibilities of things that will affect the brain. We want to do some studies with sleep deprivation. We want to do studies with caffeine. So there's a lot to test here. We need better ground truth estimation of impairment. So we had this algorithm, we had this clinical consensus, but really the test for impairment is really, it's tough. It's tough. We've asked, you know, law enforcement, we've asked people in the field, we've asked DAs, we've asked cannabis experts, like, how do you know when people are impaired? And we haven't gotten a very clear answer from anyone. And then I think there's some implementation science to be done. So we want something like this to be tested by end users in real world or in real world settings for roadside use. So with that, I will acknowledge my wonderful lab who helped collect the data and helped analyze the study and helped get our funding and our funding sources, which was a NIDA grant. So I'm about 30 minutes in. So I'm going to stop here. And I'm happy to take some questions.
Thank you. I appreciate that. We'll start with a question on the fNIRS. How does light penetrate the skull?
Okay. So so the idea is that a certain, so light is either reflected, refracted, or absorbed, right? And so there's something called the Beer-Lambert law. And again, I'm not a physicist. I'm an applications person. So there's a law that actually states how light is either reflected, refracted, or absorbed through the skull. And a lot of it gets reflected, and a lot of it is not useful. But what you can do is you can measure the amount that penetrates, and then at your source, the amount that comes back out that's detectable, and that's how you get your HBO response in the brain. So I'd encourage you, I can send you some literature, and I'd encourage you to read some of the fundamentals of fNIRS if you're interested.
Was impairment from THC and alcohol additive or synergistic versus impairment from THC or alcohol alone?
So it was additive. So people generally got more impaired when they had THC and alcohol together than either alone. But I will say that our alcohol alone condition was not enough to get people impaired. We aimed for a 0.05 blood alcohol concentration, not a 0.08. And we did that because we wanted to see, I mean, if people are impaired from alcohol and they're blowing a 0.08, there's no need for our test. That's it, done. Like they lose their license. We wanted to see our lower levels of alcohol that might be detectable from a breathalyzer. Does that affect our ability to detect impairment from THC?
Thank you. How does this technique compare to the eye movement technique for measuring impairment?
So I've seen a little bit of literature. I haven't seen a ton of literature on eye movements. From what I understand, that's fairly non-specific, and a lot of different conditions or medications can cause some eye movement impairments. So I don't know if that's ever going to be usable at the roadside. Maybe it will be. I don't know. I've never. I guess you would have to do some sort of implementation trial where you can put both together and test them back to back in the same people. But that has not been done.
Thank you. Let's see, just a second. From a public health messaging perspective, you mentioned the DREs, you mentioned field testing, but sort of what's the message as more states look to sort of identify appropriate testing measures? Sort of what do we say as they're looking for accuracy or training?
Yeah, we need a better test. We need a better test. it might not be fNIRS, but we need something. So we want something that's just, I feel like with everything that's happened, and this is my politicizing, and I know that's not the purpose of this talk, but like, we know that police officers, they're not, they're human beings and they have their biases, and some of them I'm sure are great and some of them are not great. And I don't really like that, you take a field sobriety test and whatever the cop says is the answer. Like, I really think an objective measure would be quite useful. From what we've learned in, the past few years, but really decades about law enforcement. I really like the thought of some sort of objective test that can be used that can be more just.
Yep. Did you examine the sensitivity and specificity of heart rate increase for performance decrement on memory test? Several studies have found that individuals who are tolerant to acute cannabis-induced decrements in cognitive performance still exhibit increased heart rate.
Yes. So what we did look at heart rate, because we said, oh, maybe heart rate alone could be enough. And what we found was that, number one, heart rate isn't going to cut it in the field. Have you ever been pulled over by a cop? My heart rate is like up here, right? So like heart rate is never going to be a test for impairment because it is so non-specific. If you're talking about for performance decrement on a memory test, I don't think I've run heart rate and the performance, and I wouldn't expect there to be much of a correlation, because we do find that there is increased heart rate in heavy users who may be tolerant, but it is not the same as the occasional users. What we find is that it is attenuated. So they still show a little bump, but if they don't become impaired, they don't show the huge bump. And that was pretty clear from our data. And I think a lot of the literature uses much lower doses than we do. So when we first started the study, we were like looking in the literature, and people use 5 milligrams, 10 milligrams, 15 milligrams. And what we found was that post-commercialization, that just wasn't going to get people impaired. And that's why we went up to 50 in our first paper. We went up to 80 in our second paper. So I think a lot of the literature isn't super relevant to these high doses.
Isn't the best way to assess cognitive motor impairment by measuring cognitive motor impairments with the Druid app?
You need a baseline. So the Druid app is cool. Like I've chatted with these people. We might write a grant together. I wish I had that measure in this study to compare it to the fNIRS, but they hadn't developed it when we started the study. But people vary so much. So like if I do the Druid and you do the Druid and somebody else does the Druid, there's such variation. You also need to practice a lot before you can get sort of a steady baseline score. So while, yeah, I think the Druid is super cool, I think the fact that you need a baseline is a big limitation of it. I guess in an employment setting, if you're testing, construction workers or bus drivers, or, if you have people working on a site, you could do a baseline assessment. And then if you suspect that they're impaired, you could do another assessment and use that. But I don't think that'll work roadside.
Thank you. You talked about future testing, looking at whether other drugs or concurrent use, but did you see any differences in terms of gender or age?
We didn't, actually. That's something we looked at. We looked at gender and age. We didn't see anything there. The other thing we did was we took everyone into the study. So a lot of studies are super restrictive. They don't take anyone on psych meds. They don't take anyone on, with depression, with anxiety. We took everyone into the study because we're like, this is going to have to work on everyone. And we didn't find that being on certain medications or having, a history of depression or history of anxiety affected the fNIRS data signal.
Just in terms of the testing, did you provide participants with the THC, or did they take it on their own and then enter the laboratory?
Oh no, we gave these high doses. We used oral THC, so dronabinol, which reduces its ecological validity a little bit because people aren't using dronabinol on the streets, but that's FDA approved THC, and it does get people high. So we were able to get it from the pharmacy. We didn't have to go through the rigmarole of Schedule I licenses and vaping chambers, and we got to measure exactly what they were taking. So I know a lot of studies do have people who use their own products and come in, and then you can do breath measurements or blood measurements. So it's not a bad thing to do, but we were able to administer it in the lab and have a really tight time course, which we liked.
Just within that, did you test them before to assure that they had not used products
Yes.
before they came in? Okay.
Correct. So we asked them, number one, which, some people listen, some people don't, but then we did a blood test the morning of the study.
And just also in terms of the individuals who tested, when they did their sort of self-impairment, how did they assess impairment?
Oh, when we asked people would they drive?
Yes.
But that's all we said. Would you drive a car right now? And it was a yes, no.
So no basis in terms of sort of what qualified as impairment for their own internal judgment?
That's right. So every person in the study, every 20 minutes, we did this sort of, it's called the DEQ, the Drug Effects Questionnaire. So every 20 minutes we said, are you high? Are you intoxicated? Do you feel an effect? Do you like the effect? And would you drive right now? And everybody got the same set of questions, whether or not they were impaired. And some people said yes, some people said no, some people said yes and then no. What we're doing, we're writing a cool paper right now looking at people's decisions to drive and how some people say no too late and some people resume too early, say yes too early to driving, and some people just maintain throughout the entire study that they wouldn't drive, which is appropriate for some of these people who seemed quite impaired. But what we found was that sorry, I'm getting a little tongue-tied here. What we found was that there was an age and gender effect on who would drive, and this won't come to a shock for any epidemiologists, but the young males said they would drive, and older females, older subjects and female subjects were more likely to say they wouldn't drive.
Thank you. Do you think, and your subjects think, that dronabinol dose equates to dose they typically use from edibles?
Yes, so that was how we dosed. So basically, what we did, they came in and we said, what do you usually use? Do you ever use edibles? They didn't have to use edibles to be eligible for the study, but in Massachusetts, a lot of people use edibles. We have these candies and gummies and sodas just everywhere. So a lot of people said, yes, I use edibles. So we would ask them, well, what do you usually use? And then how do you feel? So they would tell us, oh, I usually take 20 milligrams or 30 milligrams or whatever. And I get to a 6 out of 10 high. So we usually bumped it up a little because effects could be different, with a pill versus a candy or gummy, because metabolism is different. And then we would ask them if it felt like, their usual high, or if it felt more than their usual high or less. And people were really all over the map on that answer. We haven't really analyzed that data because I don't know how, other than descriptively. But we did pretty well. We wish we got more people high. We wanted to get everybody high, but we got around 60% of people who reported feeling quite impaired from the THC.
Thank you. There's also a discussion, a political discussion about high THC products.
Yeah.
And, I think there's a sort of a rush at each state as to sort of what high THC is becoming, but you used 80 milligrams. Was that the products that were available in Massachusetts, or did you just have that as your cutoff for the testing?
Oh, okay. So first, our cutoff, like I said, first thing we did was we looked at the literature. The literature used the low doses and still got people impaired. And we were like, great. So we did some piloting and we realized that people just weren't feeling it. They just really, or they were feeling it a little bit, or they were rating maybe a 20 out of 100 and high. And they were performing perfectly fine on the tasks. So we thought, oh, maybe we need to bump it up a little. So we tried 50 milligrams, and that was our first study. We had a cap of 50 milligrams. And there was still a group of people who just didn't feel it. They just didn't feel it. And then for our second study, which is the one where we used alcohol as well, and we did the resting state connectivity, we asked the IRB for approval to go up to 80 milligrams. And quite honestly, we didn't have a lot of AEs. We had 2 AEs where people passed out, but those were at much lower doses. We had some nausea, but those were also not usually not the 80 milligram people. Those were people who were just much more casual users at 20 or 25 milligrams. So we really, I think it says a lot about the commercial market here. And I'm not a policy expert, so I've never gone into the shops and really seen what they have. I guess I should. But what I would anticipate is that people are used to really high doses now.
Thank you. How has fNIRS compared with other imaging modalities such as fMRI and PET in assessment of regional brain metabolism and as a correlate of cognitive performance?
So that's a big question. So fNIRS is new. I mean, it's been around for a decade or so, but if you look at fNIRS publications versus something like fMRI or PET, fMRI and PET are still so much more commonly done than fNIRS. And the reason is you get the whole brain, right? So if you do an fMRI scan, you get all these cool structures that are important in addiction. You get the nucleus accumbens, the reward structures, the amygdala, the hippocampus, all the deep brain structures. The enormous limitation of fNIRS, which is why I think a lot of people aren't interested in it, is you only get 3 millimeters into the brain because that's the penetration of light. So for our purposes, the prefrontal cortex, that's fine because that's what we're interested in. We're interested in, right here, forehead, that's decision making, and that's where cannabinoid receptors are. Fortunately, it was just a kind of a fortunate coincidence that you have a lot of cannabinoid receptors in your prefrontal cortex, and that's where a lot of this higher order decision making takes place. But asking how it compares to the other modalities is a tough comparison because we didn't get effects in association cortices, and we didn't even get the back of the head or parietal lobe or any of that. So we were in a much more constrained topographic area. But I'm not sure if there have been direct comparisons of PET imaging for regional metabolism and fNIRS. I'm not sure if anyone's ever done those in the same participants to do sort of this head-to-head comparison. I think it is more limited, to be fair. I think it's not as robust as fMRI or PET.
Thank you. Second, another question. Could this be used to differentiate impairment from THC and impairment from synthetics like Delta 8 or Delta 10?
I have no idea. It's an excellent question. Nobody knows much. People don't know very much about Delta 8 or Delta 10 THC in general. I was on a study section recently where somebody proposed looking at Delta 8 THC, and reviewers were super excited about it because they were like, oh, we don't know anything about this, and this is so understudied, which I agree with. So I have no idea. I would assume it would look similar because what you're doing is you're looking at decision making and you're looking at compounds that affect cannabinoid receptors. And from what I understand, these are all these compounds will affect your cannabinoid receptors and decision making areas of the brain, but I haven't tested it myself, so I don't know.
Thank you. Is there any either medicine or physical aspect that would mimic the results that you have from the fNIRS with THC use?
That's another question that we need to answer. So you don't want somebody on, an anti-epileptic medicine to look like they're high from THC because they have reduced connectivity in the prefrontal cortex. So I think for this to have legs, it would not be a standalone method. I think if this were ever to become practical in the field, you would need both the the measure of impairment in the brain, whether it's reduced connectivity or reduced activity during a memory task, and some sort of positive biological screen for THC, because we just can't test every possible compound. There's thousands in large enough groups. So I think that it's an excellent question whether certain medicines that affect the brain will make the brain, quote unquote, look like they're impaired from THC, and that is certainly what we don't want. You could also imagine, triangulating, fNIRS measurement of brain impairment, something like the Druid, where they show cognitive impairment on the iPhone app and a urine screen. You might think, oh, that's so much. Oh my gosh, like that's burdensome. But these DRE assessments take an hour or more. We asked our DREs to do it in 45 minutes because we needed to get on with the study, and there was a lot we needed to do while they were high. And that between the fNIRS and our own testing and the DRE assessment, we said, can you please keep it to 45 minutes? Some of them did, some of them didn't. The DRE assessments are really long. So, if you do a 6-minute fNIRS scan, the Druid app takes 2 minutes, 3 minutes, and you have them pee into a cup, or you take a saliva measurement. I don't think that is an unreasonable ask compared to the DRE assessment.
Thank you.
But I think it's all pieces of a puzzle. Like, I can't imagine anything that we have to be standalone because THC is so complex.
Yes, and some measurements from the state is that many of the stops relate to THC and some other substance.
Yeah.
So testing would have to identify whether that's alcohol or some other substance.
Yeah, that's right. And like I said, alcohol is easy. We've solved the alcohol problem. So breathalyzers can detect, the amount of alcohol in your breath, and we metabolize 1 drink per hour. And we've done all the work to show that at 0.08, your risk of crashes goes way up. So 0.08 is what we're willing to accept as a society for alcohol intoxication. So if somebody is using alcohol and cannabis and you do a breath test and they have a 0.08 or 0.09 or 0.1 or 0.2, it happens. That's it. Like, you don't need to get into, what was cannabis doing? Was cannabis affecting the brain? It doesn't matter for a practical purpose. Scientifically, as a neuroscientist, that's super interesting to me. But from a societal level, if they have alcohol on board, it just doesn't matter. The other drugs, I think, are much less common. So THC and alcohol are commonly used together. The other drugs, the illicit drugs, are used less commonly. But I agree. I think there's work to be done to see how drug combinations work.
Are there off-target effects from cannabinoids on receptors other than cannabinoid receptors?
Oh, I'm sure. There's so much we don't understand about how cannabinoids affect the brain. So there's the CB1 receptors that are in the brain and the CNS, and then there's the CB2 receptors that are in the periphery. But it causes a cascade of chemical consequences in the brain. So I'm sure cannabis affects other receptors in the brain.
This is somewhat unfair, and it's not part of your study, but in terms of the DREs, sort of their ability to identify impairment, seemed like there was a significant range between sort of accuracy. Was there any sort of experience associated with those who more?
Yeah, so we had a DRE trainer. He was super interested in the study. He was like, oh my gosh, I'll help you whatever way I can. This is so great. So the DRE trainer did super well. He was really good. But of course, he couldn't do all the assessments because they're long and there were a lot of study visits. And, we thought, oh, should we train the study staff? Some studies do that. They have somebody train their study staff. But we were like, no. We want people who are doing it on the street. We want the professionals. So then he brought in some of his other people who he's trained to do some of the assessments, and that's where we got less accurate responses, and we shared it with them, actually, in a polite way. You don't want to be on the wrong side of the cops. Like, I might get pulled over by one of them someday. So very politely, we shared our results with them, and basically, how we described is it was a problem with the test. That's what we said. We were like, the test is really tough. You have a tough job here.
I think, again, sort of going back to the public health issues here in Pennsylvania, we may be debating adult use, and one of the major questions and debate areas that comes up is driving impairment and how to measure.
Yeah, it's a tough one. Well, and like I said, I think in the Q&A I mentioned this, but also in the talk, we don't have a definition of impairment. I've gone to the to people who determine whether elderly people are safe to drive. I asked them. I said, how do you decide when somebody can't drive anymore? Like I've asked policy experts, I've asked drug experts. I'm like, what is impairment? And there's no legal definition of impairment. It's just what you perceive as impairment. So it's really, and then, with alcohol, we have a really nice model, but it's taken decades of work to compile enough data, and alcohol is just an easier drug because of its metabolism. I don't know. I mean, if I were brought in front of Congress tomorrow, I would explain the complexity of the problem, but I don't know the solution.
And I think there's also sort of the questions for individual. When did you last use? How long ago?
Yeah.
Sort of what was the content, and that impacts obviously the individual in the field who's trying to do the test.
Yeah. So one other point to bring up, which is really critical, is that there is some evidence that chronic cannabis use has cognitive effects, right? So I think Marilyn Hustis has published some of this, who's a giant in this field, that people who are cannabis users and use daily will do poorly on some of these tests, even if they're not acutely intoxicated. So a DRE can be picking up on that for all we know. They might not be performing the test very well because they're a chronic cannabis user, but I think that's a strong statement to make, that if you're a chronic cannabis user, you can't drive. Like, I don't think we're going to go there anytime soon. So no, you're right. It's really hard.
Well, we're at the top of the hour. We've had a lot of engagement with the audience, so thank you so much for taking the time to be with us today. We look forward to your further studies in this area and how it translates into the field. So thank you for taking the time, and to all our viewers, thank you. And next month, there will not be a webinar due to the conference, and we'll start back up in September. So Dr. Gilman, thank you very much for taking the time with us.
Thank you so much. This was really fun. Thanks. You had great questions.
Thank you. This concludes the webinar. Thanks, everyone.
Bye.
Bye.